This is Unit 7, Section 3, Key Terms. Our first term is abduction. This is when we move something away from the body. So if you are doing range of motion and you move the resident's arm this way, you are moving that away from the body. That is abduction. Our next term is active range of motion. Active range of motion is when a resident performs an exercise on their own. We may assist them with setting up that activity, but they are able to complete the activity on their own. For example, you may set your resident up in their wheelchair with a set of pulleys, but they complete the pulley exercise on their own. You may help your resident transfer onto and set up on an exercise bike, a recumbent bike, but they complete the activity on their own. That is active range of motion. Our next term is adduction. So we said with abduction, we are moving away from the body. Adduction is now when we move the limb back towards the body. Our next term is extension. So when we are doing range of motion and we extend the arm, this is extension. When we are doing this, our next term is external rotation. We are externally rotating this joint when we extend it. Our next term is flexion. When we flex that arm, bringing it into the body, we are now internally rotating that joint. So our next term is internal rotation, and that is to move that joint inward. Our next term is passive range of motion. This is when the resident cannot complete the activity and we do the activity for them. Passive range of motion is when we move that resident's body through all of its normal motions. So we move the fingers for that resident. We move their wrists. We move their arms. We do all of the range of motion exercises for them. Our next term is range of motion. So we have had active and passive. Both of these are type of range of motion. Range of motion is simply moving your body's joints through its normal activity. Our next term is tubing. Tubing is hollow catheters. They're usually a rubber type tubing that carries liquid or gas in or out of the body. We have lots of different types of tubing. We have oxygen tubing, we have feeding tube tubing, we have nasogastric tubing, or IV tubing. So there are lots of different types of tubing. And our last term is to transfer. So when we transfer a resident, we move them from one surface to the next. Our next section is going to discuss moving and transferring and lifting residents. The first thing to keep in mind when you are moving a resident is to plan the move. Make sure that you have checked their care plan, that you know how that resident transfers. Do they have any special needs? Do they have a weakness on their one side? Do they have an affected limb? Do they have a brace that they're supposed to use? If you do not know how to transfer a resident, if you have not transferred them before, ask for help. Make sure you have everything that you need in place. Explain what's going to happen to the resident so that they can participate in the transfer. And be sure that they understand what needs to be done. Check your care plans for lifting or transferring devices. Some of those things may be a lift sheet, if you're using mechanical lift, a Hoyer lift. There's two different kinds of mechanical lifts. There's a Hoyer lift, which is a full body sling lift. This is for residents who cannot bear weight on their legs. And then we also have a standing lift. It may be called an easy stand or a standing pal or a pal lift. These are for residents who can bear weight on their legs. In Most cases, a standing lift is a 2-person transfer. Most facilities require 2 staff when using any mechanical lift. A full body sling or a Hoyer lift is always a 2-person transfer. You must use 2 staff if you are using a Hoyer lift or a full body sling lift. Lift sheets are used in beds to scoot residents up in bed or to help with positioning. We also use transfer belts when we are doing transfers or repositioning or walking a resident. A transfer belt simply goes around the resident's waist, it buckles through, and then we have this to hold on to. Transfer belts help us with positioning and with transfers so that we aren't pulling on residents, decreases the risk of things like shoulder dislocation, and increases safety. When we are working with residents, we want to make sure that we are positioning the bed at proper height. So, when you leave a resident in the bed, when they are resting, when they're alone in the room, you want that bed in low position. When you are transferring residents in and out of bed, you want to adjust the height of the bed so that that resident can have their feet flat on the floor and sit comfortably at the bedside. When you are working with a resident in bed, performing cares, you want to raise that bed up to what we call the working level. This is so that you do not have to bend over your resident. You can have the bed at a good working height so that you can stand, maintaining good body mechanics. Some safety reminders with moving residents, transferring residents. Always check and use brakes on equipment. Brakes on walkers, brakes on wheelchairs, on lifts, on shower chairs, tub chairs. Anything that has a brake on it, you should be using. Make sure that the equipment is in good working order. When you're transferring one resident from one surface to another, make sure that you're moving them towards the strong side. If they have an affected side, we want to transfer them towards their strong side. In the example of maybe hemiplegia that we've discussed previously, you want to move towards the strong side. If that resident has any tubing, catheter tubing, oxygen tubing, if they have a feeding tube, make sure that you are carefully moving that tubing so that we're not tugging on that in any way. When you're transferring residents, whether it is with a mechanical lift or transferring them manually, you want to make sure that the floor is free of clutter and debris and tripping hazards. Residents should always have non-skid footwear on for all transfers, whether that is grippy socks, shoes, slippers with rubber bottoms or non-skid soles. They have to have non-skid footwear on their feet for all transfers. Make sure if they have a prosthetic or a brace that it is applied correctly so that they have that for mobility. Don't lift under their arms. That's what we use the transfer belt for. Also, do not allow a resident to put their arms up around your neck. If the resident needs something to hang on to, if you are holding on to a transfer belt, have them grasp your forearms or your biceps. But do not allow a resident to put their arms around your neck. This could result in an injury. Make sure that you are transporting residents cautiously in wheelchairs. Make sure that you're going around corners slowly and safely. Make sure that canes and walkers are in good working order. Make sure that the rubber tips on canes aren't torn or damaged that they would catch in the carpet. And then, again, make sure that your resident knows what is going to happen. When you are transferring a resident, when you're standing them up, make sure you look at them. Observe them. Are they dizzy? Are they lightheaded? Ask them when you stand them up. Before you start walking, when you go to stand a resident up, are you feeling dizzy or lightheaded, or are you feeling okay? We want to make sure that they're okay before they start to move. Residents that sit a lot When we go to transfer them and stand them up, they can have orthostatic hypotension. When they stand up, their blood pressure lowers and they get dizzy and lightheaded. We want to make sure that this is not happening because we don't want them to have a fall or a dizzy episode. There are some psychosocial, some of those emotional and mental concerns for residents with transfers. Allow them to participate in the transfer. Encourage them to participate in the transfer. Make sure that they know what's going to happen. Communicate with them. Okay, on 3, we're going to stand up. And then count. Count with me. 1, 2, 3. And on 3, you complete the transfer. Be aware if your resident has a fear of falling. Be aware if they have a fear of being alone. We don't ever want to leave a resident alone in a situation where they don't feel safe. So make sure that we're using breaks. Again, when we're transferring, make sure that we're reassuring residents that they are safe. Our next section is going to discuss the importance of range of motion. So range of motion is important for residents that have limited mobility or that are immobile. Range of motion is going to move all of our joints and our extremities through their normal motion that we would do if we were mobile. This helps maintain muscles. This helps prevent joint stiffness. This helps prevent complications such as contractures. We have 2 types of range of motion. We have active range of motion, where the resident completes the activity by themselves. And then we also have passive range of motion, where we do the activity for the resident. We may, for active range of motion, set that resident up, but then they do the activity themselves. For passive, we complete the whole activity. The purpose of range of motion is to prevent complications and deformities such as contractures. This helps manage pain. It helps with circulation. It helps with joint function. Range of motion helps, especially with our residents that are immobile. It helps promote a feeling of well-being. And it helps to increase independence and maintain function. When we are doing range of motion, we want to move those extremities gently and smoothly through the motions. We don't ever want to do passive activity on a resident who can do so independently. We never force a joint to move beyond what is comfortable. We want to allow time between exercises for those joints to rest. Make sure that you are asking your resident, does any of this hurt? Make sure you let them know. If anything is uncomfortable, let me know and we will stop. So that they know if you are stretching a joint beyond what is comfortable for them, they need to let you know so that we can stop doing that. If you are doing range of motion, passive range of motion, make sure that we are doing so in the resident is lying on a bed. It is much more effective than trying to do so in a wheelchair. We can move the extremities through a much better range of motion lying in bed than we can in a wheelchair. Our last section of this unit is going to discuss special care needs for residents with joint replacements or fractures. There are a few different types of joint replacements that we work with in our nursing facilities. Most commonly, these are going to be hip replacements or repairs, knee replacements or repairs, and perhaps a shoulder replacement or repair. We want to make sure that anyone that has a hip or a knee replacement or repair, that we are maintaining their weight-bearing status. The doctor will determine how much weight bearing they are able to have on that joint at any given time. Weight bearing status can change. It can go forward and backward. If that person was weight bearing is tolerated, they go to the doctor and the doctor takes an x-ray and determines that the joint is not healing the way they would like it to, they may back them up to toe touch weight bearing or 25% weight bearing. So we want to always make sure that we are checking what a person's weight bearing status is. Make sure that you're double checking with the nurse on any restrictions that that person has. When the person is lying down, if they have a hip or a knee replacement or repair, we want to avoid having them lay on any incision for a length of time. We want to make sure that we are putting a pillow between the legs to cushion that joint and to keep their legs in good position. Especially if we turn them on their side, we need to have a pillow between the legs. When they are sitting in a chair, we want to make sure that that person is not overextending beyond 90 degrees. So we want to make sure if they're in a chair or on the toilet, sitting at the bedside, that they're not leaning over or bending, picking things up, doing anything that's going to overextend that new joint until it is totally healed. You may have to ask for a toilet riser for your resident. For that reason, they maybe need a reacher or a grabber so that they can reach items. We do not want them to overextend that joint.